as you'll see, Glenn is going to highlight the complexities that there are with the legal governance more generally of health AI. And Glenn's work is actually foundational in this area. So, we're really grateful for what he's done so far. So I thought I would make some comments about the benefits of regulating to stop AI harms from happening in the first place. So to try to prevent bad things occurring, as opposed to using law after the event. So that's what we would call private law. So using tort law, for example, to punish somebody who has done something or harmed you. So I, thinking about this, I think most legal scholars understand, even if the public and patients don't, the incredible uphill battle that patients face to successfully sue a doctor or health professional for negligent treatment. Patients are often too sick or they lack resources to launch these kinds of claims. And even if they do, they face many difficulties in establishing what we call causation, which is the evidentiary link between the actions of the doctor or nurse and the harm suffered by the patient. And so we already know this now, that only an incredibly small percentage of negligence is actually ever litigated, and even vanishingly small percentage of that are patients compensated. And I think that the present difficulties that patients have in this regard will be greatly exacerbated by the black box of algorithmic decision-making. In the future, as many predict, and is rapidly coming to pass, all doctors will be supported by AI in their decision-making, and in some cases may replace actual professional judgment or decision-making. And one will only have to wonder then how much more difficult it will be for a patient to show that flawed decision-making resulted in harm. And, if doctors can't look under the hood of AI reasoning, I ask myself, how can they then demand trust on the part of patients in their decision-making? So, it's really part of the physician-patient encounter that the patient feels they're able to trust the physician. But how can you demand that trust when you can't actually account for the reasoning that has gone into the decision that they see? So these and other worries underscore the essential need to me of having adequate regulation of safety, quality, and privacy of AI before they come to the market, and not to try to respond to the problem once they manifest. Because if you're relying on medical negligence claims, it's not going to be much of a deterrent. There's be so little of it in response to any actual problems. And I also think that just as with prescription drugs, even although a doctor might not understand the exact chemical interactions, the doctor can generally trust the processes that have gone into the safety and approval of a prescription drug, right? So I think our focus and a focus of our research team actually is increasingly turning to the role that Health Canada plays, and similar regulators in other countries, the role that they must play in improving the safety and quality of medical devices with artificial intelligence. And that includes not just hard devices like an implant or a wheelchair, but has been interpreted to include just software. So Health Canada has the ability to regulate there. And I think a focus on federal regulation is quite important in general. As you might have noticed, governance of healthcare leaves a little bit to be desired, with the splintered accountability between federal and provincial governments. So a focus on the federal government here, Health Canada, we really have this ability to ensure that there are common standards across the whole of Canada that will be beneficial, I think, to innovators, to clinicians, and to patients. So our team has started working on this question, but we have already, our work already suggests that there are some concerns with the present approach that will need to be worked on. So, for example, the present regulatory framework requires the innovators themselves, the applicants for a license from Health Canada, for themselves to determine the risk of the product. And that then determines the extent of the regulation that attaches to it. And so I think, we have to I wonder about how often this is audited, how frequently these kinds of decisions are reviewed by Health Canada, but it's quite hard to get that information at the moment. So I think we'd like to see more transparency in how regulation is occurring. A second thing that we know is that with machine learning, the kinds of regulatory approaches that we have are really going to have to rapidly evolve. Right, so right now, you get approved today in March 2023, and that's kind of meant to serve sort of in perpetuity, that you're safe to go unless there's some reason to recall the drug or the device. But with machine learning, by definition, it's evolving and changing over time, and might be a completely, quite a different product in how it works. So we're really going to have to think about how we regulate over the life cycle of a medical device. And we've learned that from prescription drugs as well. But we're going to have to be novel and effective and efficient in how we do this if we want to really liberate machine learning for health AI. I think another thing that we worry about a bit is that, well, not a bit, Health Canada has yet to say that they will specifically attend to issues of algorithmic bias, which can lead to safety concerns, but also just straight up discrimination worries, or to concerns around privacy. So we are wondering if this is a place where Health Canada should actually be asking of the innovators, have you complied with, have you done your due diligence to ensure that you have the best data set, that you have done everything you can to ensure that your product is not entrenching any kind of bias or discrimination? And have you attended to the privacy issues as well? And so this will be a question of division of powers and constitutional interpretation. Can Health Canada go that far when it's regulating the safety and quality of medical devices? And how will that intersect with privacy laws at the provincial level and human rights laws at the provincial level? So I think this is something that we're planning on working on. And, finally, I would note that we have a general concern that sort of in the innovation race, all countries are really seeing, the possibilities of AI and health AI in particular. And this gives us concern that perhaps the focus is too much on fostering innovation and not enough on regulating in the interests of the public. And so I don't see these as trade-offs. I think the public good is what the regulator should focus on. And public good includes not only protecting, the safety and quality of the product and ensuring that patients aren't harmed, but also ensuring that, we have the most effective, efficient regulation, that we're basically supporting amazing innovators like Anna, as you'll hear in a minute, and supporting great products, but weeding out bad ones, right? And that's in the public interest. But just to focus on, we must not regulate perhaps because that might unduly impact innovation. I don't see that as much of a winning argument in my view. But I think there's a definite kind of concern about that globally as well, and we want to make sure that bad AI innovators aren't just going to other jurisdictions with sort of lighter regulatory touch as well. So that's something that we have to think about from a global perspective. Anyway, so that's my 5 minutes of fame, and we'll turn it perhaps to Teresa.
So one of the things I spend a lot of time thinking about, I do information law and policy, and I spend a lot of time these days thinking about data and in particular personal data in the context of AI innovation. And certainly this is something where we see a lot of issues in the healthcare context when it comes to AI. And so on my slide, I really just wanted to highlight some of the challenges that I'm seeing in this area. And so that's what I'll do. One of the challenges is, of course, the pace of evolution of technology, as well as the shifting and changing legal regimes. And so, I mean, if you had to sum that up in a word, it would be uncertainty. And I think that that's a challenge for developers. It's a challenge for regulators. It's a challenge for all of us. And so you have technology that is moving so fast. I mean, really just in the last couple of weeks, the world's head has exploded with ChatGPT, for example, and all of the implications of ChatGPT and all of the ways that it's going to affect us in so many things that we do. And it will also have impacts in the healthcare context. So that's just an example of just how quickly technology shifts and evolves, and so and raises new issues that we have to think about and respond to. And maybe some of the things that we were already starting to develop as responses don't fit so well the sudden change in direction that the technology may have taken. So that's certainly a challenge. And changing legal regimes also create uncertainty. So in Canada right now, for example, we have a bill before Parliament that not only would reform the private sector data protection law, but it also proposes an AI governance regime, AI risk regulation. And so that creates uncertainty. And I'm not going to get into why this particular bill creates even more uncertainty than perhaps it needs to, but we also don't know if this bill is going to pass or if it's going to pass in what form. And and it has created a certain amount of anxiety amongst developers and civil society alike. And so and it makes it very hard to predict what the landscape will look like, how this bill for AI governance is going to intersect with, for example, more specific regulators of healthcare devices that use AI, and how it's going to intersect with other regulatory schemes that might be existing. So uncertainty. This is a challenge, and it's likely to remain a challenge for some time. Another challenge that you have with respect to data in the Canadian, and this is particular to the Canadian context, so forgive me if you're tuning in from outside of Canada, just bear with me for a minute. We have different laws for different categories of data. So we have public sector data protection law for public sector data. And so, for example, health administrative data, data related to the public administration of the healthcare system, is governed by one set of data protection laws, public sector, with different law for each jurisdiction in Canada, federally and provincially and territorially. Data from the private sector is governed by separate private sector data protection laws, one federally, one in Alberta, one in BC, one in Quebec. And personal health information is governed by, so the defined category of personal health information is governed, typically governed by specific provincial personal health information laws. And so that also adds to the complexity, because as Glenn, and I was going to say, as Glenn has pointed out, but I'll say as Glenn will point out, the kind of health data, the sources of health data have changed. And so where at one point we might have referred to, health data as being data that comes from patients or that's about patients, and therefore it's personal health information, and therefore it's governed under this regime, and here are the rules. we're finding in AI applications that these may involve health administrative data, they may involve personal health information, they may involve health data that's extracted from private sector sources that are not governed by personal health information legislation. And so, and then of course, there's also data about health that is drawn by inference, which is its own category of data. And so we have many different sources of data that might be used. And this makes, again, governance challenging and confusing. We also are seeing a proliferation of different normative approaches to data governance. We have research ethics boards that are established typically under personal health information legislation and through the hospital and research system in the hospital. But there are other data governance initiatives that are being proposed and experimented with as finding ways of ensuring that data is appropriately governed when it is to be used in AI, for example. So safe sharing sites, data trust, data sharing platforms. Some of these may be created by statute or governed by statute. Some of them may be non-statutory. We have organizations adopting voluntary ethics frameworks and so on. And so again, you have a normative diversity there that can be very challenging in this context. Another issue that I see is that core concepts like consent and anonymized data are increasingly coming under challenge, and this can be, obviously very problematic. Consent is under challenge in a number of different ways, and consent is different under different legislation. So under public sector legislation, for example, these are not consent-based frameworks, and so consent plays a very different role under that legislation than it would under private sector legislation. But consent under private sector legislation is very different from consent under personal health information. In the health information context, consent is taken typically very seriously. In the private sector context, you've seen all of the challenges that we have with consent and long privacy policies that people don't have time to read, and questions about whether consent has been genuine and so on. So consent is fragmented across those sectors, but it's also, there are also questions about how consent is evolving under legislation as legislation changes, how exceptions to consent are framed for research and research-based uses of data. And there's a lot of pressure to make more data more readily available for AI and innovation, and therefore to create more exceptions to consent. And so consent is a concept that is being challenged. Anonymized data is an interesting one as well. We have statutory frameworks, and the GDPR is like this as well, the European General Data Protection Regulation, where our data protection laws protect information about identifiable individuals. So it's personal data that can be linked to a specific individual. In theory, if data have been properly anonymized, they're no longer about identifiable individuals, and therefore they're not personal data. And so they fall outside and are out of scope of the legislation, and laws have been changed to make that clear that anonymized data are out of scope. And there are now issues arising about whether anonymized data should be out of scope because of the risk of re-identification. What happens if there is re-identification? What are the boundaries between data being in scope and out of scope? And should there be separate governance for anonymized data? And this is a live discussion, and I think another challenge. The intersection of data protection issues with other issues such as bias, discrimination, data quality as well, are all, I think, important and pressing issues in the AI context, that it's not just data protection law, but there are these other considerations which may involve other regimes, or which may put pressure on data protection regimes. And then I'll just flag, again, very briefly, what I see as emerging norms or concepts that can be challenging as well. Social license, a term that I am deeply suspicious of when used in the data context, but which still has some role to play there. I think it just has to be defined carefully. This idea of what the general public, what the public will accept or not accept, and what they're, concepts of group or collective privacy, and that's linked to anonymized data. This idea that it's not necessarily all about protecting privacy to protect individuals, but there may be justifications and need to protect data, to protect group or collective interests. And then at the same time, in the data protection context, trends towards greater individual micro-control over data that might create new norms around the ability to opt out, not only to give consent, but to opt out, data erasure, and other things which can also be challenging for AI. So I've just given you a quick overview and snapshot of some of the things that keep me awake at night, and just why I often have big bags under my eyes, because there's a lot going on. Always interesting, always dynamic, and lots of important public policy issues to consider in this context. So I'll stop there. Thank you.
Alors, bonjour à tout le monde, c'est un plaisir d'être ici avec vous. Je suis désolé que je suis un petit peu en retard, mais I didn't, this morning when I woke up at 8:15 in the morning, or got on the plane at 8:15 in the morning, I could deal with a plane being canceled, but I didn't factor in that there is an American arriving here in Ottawa with higher status than I am that would cause my particular flight to be delayed a little bit more at the gate. But through the magic of Zoom, I was able to listen into the comments before me. So it was a pleasure to hear everybody. It was fantastic. But it's a good thing to have a Zoom, right? So if you don't mind the next slide. These are just my disclosures to start off with. I'll go to the next slide now. So I want to start by saying we shouldn't lose sight of the question, why the heck are we doing any of this, right? So why is it that we're trying to implement medical AI? And I often think about this as a 2x2. There's a question about the different kinds of functions we're trying to achieve by medical AI: imaging, prognostics, diagnostics, treatment. But then more importantly, what is the goal? What is it we're trying to achieve? And here I want to suggest there are 4 things medical AI could be doing. One is to democratize expertise. So take the most fancy ophthalmologist or cardiologist or oncologist you have here in Canada and make that available to people all over Canada in rural areas and all over the world. Second thing is to automate drudgery. The idea here being, let's take what physicians do well, let's have them do more of it and move more of the things that are paperwork, billing, that kind of stuff to AI. A third is the idea of optimizing resources. Let's decide amongst rival claimants who needs priority, and especially in a socialized medical system like Canada, we know not everybody can be helped immediately at the same time. And the last one is pushing frontiers. Let's do something we're doing really well, like determining whether a lesion or a tumor is cancerous, and let's do that even better. So almost all of the hype and a lot of the money is flowing in that last box, pushing frontiers. But one of the things I want to suggest to you is the value proposition for the world is really in that first box, democratizing expertise. We could give the world Canadian-style medicine, maybe even slightly less good than the kind of medicine you have access to people all over the world. That would be a huge benefit and bonus. And one of the questions is whether the market is aligned to do that. If I can have the next slide, please. So I want to start with just some use cases, just to give you some examples, and some earlier ones came out in Colleen's talk and some of the others. One is just the idea of choosing a cancer therapeutic. So you have a set of different possible treatments for oncology. Which one do you use for a particular patient? Could AI help with that? Second is ICU bed allocation. You have a number of claimants to the ICU. Maybe there's been an accident. Maybe there's been an outbreak. Can AI help us determine who should have priority if we can't help everyone? Third is, and I just presented recently to the Fertility Society of Canada, the CFAS, and this one came up, which is deciding what the starting dose for FSH during ovarian stimulation, so to trigger the follicles to basically produce oocytes, eggs. How do you determine? It turns out very different, and different clinics do it differently. Another is using AI to actually look at embryos when they're developing and determining which of them has the highest chance of a successful pregnancy and ought to be prioritized for implementation. And this last one, again, I go around the world just giving these talks, and people say, well, have you thought about this, or what about this study? So this one, don't ask me to explain this one, but it's endocardial boundary detection for LVEF. And this was the echocardiologists were extremely excited about this. And so I'm excited about it too, even though I can't explain it. Okay, next slide, please. So this is like my master slide about like everything I tell people to worry about. So if you're going to remember one slide or take down one slide, this would be it, I would suggest. And this is my attempt to say, let's go through the life cycle of building an artificial intelligence agent and determining what are the main issues at each of the stages. And I want to prefigure this by saying, listen, I'm an ethicist and I'm a lawyer. I'm not a CS person. So this is the way I think about the problems. If you're actually building one of these, you do it a different way. But I think this is a helpful first approximation. The first phase is just the question about acquiring the data. Among the issues you have to ask yourself is, do patients need to be explicitly consented if we want to use their data? All the electronic medical records and the data that's gone into them that you've produced over the course of your lifetime, has anybody ever asked you whether artificial intelligence agent can be trained on it? Is it enough to be notified, or do we need actual consent? What happens if we strip enough identifiers from the data set? In the US, we have 18 identifiers we standardly strip. Is that good enough? Can a hospital system condition, or a health system condition, your participation in getting healthcare on your being willingness to share your data, in the idea that the data is used to build socialized agents for everyone's benefit? How representative is the data we're going to have? If you are collecting data only from high resource settings and from fancy academic medical centers, your data set is going to reflect that. I often say, I'm 44, so as a middle-aged white guy from Boston, I am like ground zero for every data set in the world, because that is where most of the data is collected. Large academic medical centers in Boston. I'm not joking about this, right? So I'm not so worried about me being a data point and what represented in the data. But what about people in rural settings? What about racial and other minorities? What about First Nations peoples, right? How do we ensure that this is going to be well represented? And what governance do we think patients should have on the data? What say should you have on whether your data is used potentially for projects that you might find objectionable, or at least not wanting to participate? Can we think of ideas like trusts or unions or other kinds of settings and setups of legal governance that are not just simply consent or notice sorts of things? That's all in the first phase. Second phase, we want to build and validate a model. How will we know when the model is good enough to be used on real patients? What standards of validation we put in place? As Professor Flood said, what kind of ex-ante regulation do we need before these are even allowed into hospital systems? Do we do risk classification? I can tell you the vast majority of AI used, at least in the United States right now, there's no regulator outside the hospital system that's looked at it. It's essentially being used as are other tools in a quality assurance sort of way, or that's the way they label it. And the idea being here that we really want to have, especially for some applications, a lot of pre-market review before it's put in. And there's some tensions here between the intellectual property desires, right? Because in an ideal world, make the models as transparent as possible. We'd allow a lot of people to look at them, a lot of people to test them. But there's two problems with that. One is the risk of adversarial attacks. The more you know about a model, the easier it is to attack it and to hack it, and to, for example, perturbate a single pixel and suddenly change something that the human eye can't detect that makes something that's benign now look like cancer. And the other is a question about the intellectual property regime around this. We want to incentive people to build some of these models, and it's expensive. What happens if we don't have trade secrecy or other protection around it? And how do we mediate those two interests, and what can government do to do it? Third phase is testing the model in real world settings. What, if anything, should a patient be told about the fact that an artificial intelligence is being used to partially direct their care? Does there need to be a separate informed consent? Can patients opt out? What about cases where the analytics is used to steer resources, for example, designing nursing shifts or designing how to staff a particular care team? Is that the kind of thing patients need to be told? I'm going to discuss in a moment questions about liability, but over all of this, as Professor Flood said, there is this question about the regulator's role. To what extent do we want ex-ante regulation versus ex post through things like the tort system? Finally, broad dissemination. Congratulations, you've got a model that works. That's not easy. It's actually improving the lives of Canadians. It's helping people in their most vulnerable when they're facing healthcare deficits. But it turns out it's only available to people who have paid for concierge medicine, or it's only available in high resource settings, not everywhere. If these models are built on the data of people across the country, how do you ensure that it's disseminated and available and licensed in a way that's also equitable? Can I get the next slide, please? Okay, so not when I'm talking to medical people, but when I'm talking to lawyers, they're often like, okay, yeah, AI, I read about it, like self-driving cars and all this other stuff and ChatGPT, and what's so different about the medical context? And so I got this enough that I decided to make a slide for it. This is my slide to try to give the answer. And the answer is, unlike other areas of life, there's a lot of intermediaries between me, the patient, and the care that I get. Right? And this busy diagram actually oversimplifies it to some extent, right? There's the AI developer who's making a ton of choices beyond the underlying algorithm. Is it going to be locked or is it going to adapt? How many different levels of inputs? What is the choice architecture around it? The product might undergo a pre-market review by a regulator. That's a second person who's involved. A third might be the hospital system that has to decide whether to purchase it or not and how to implement it. Based on their decision, they might offer it to physicians, or physicians might themselves decide to buy or to use this, and that decision might impose it on nurses and other hospital staff. There are insurers, both payers, like the provincial payers, who are deciding what to reimburse, whether they'll only reimburse what the AI recommends, whether they'll reimburse the cost of the AI itself, as well as malpractice insurers who will determine under what circumstances following or not following the AI will have an impact on whether malpractice is insured against and paid for the liability. So that's just to say that if you're trying to decide a system, you have to think about how all of these different pieces work in tandem, and you can get into a lot of trouble if you change one of them without thinking about the ramifications for the others. If I can get the next slide. So I want to say a word about liability, and this was already mentioned a little bit by Professor Flood, and that is that when we think about liability, and this is from the US, but it's not that different here in Canada, medical AI will inevitably make errors. Why? Because physicians inevitably make errors. It's not the case that adopting a medical AI will automatically mean there's zero errors. The question you want to ask yourself is, there going to be fewer errors or more errors? Are going to be less serious or more serious? The problem, though, is that our tort system and the malpractice system in some ways creates some incentive that causes a certain conservatism. So I'm now drawing on a paper here from with Gurka and Price that I did from JAMA, and this figure tries to kind of oversimplistically walk you through just a simple question. Imagine you have a question of which of two doses to give a patient with ovarian cancer of a drug, 15 milligrams per kilogram every 3 weeks, or a different dosage, right? And one of the big advantages here, we were told, is that medical AI will make it easier to individualize the care for patients. Different patients have different needs, and AI will resolve that. So the first question in the second column is, what does the AI recommend? And to simplify, we could assume the AI makes one of two recommendations. In real life, it's more complicated than that. The third column says, well, the AI could either be correct or incorrect. Correct means it produces a desirable outcome for the patient. Incorrect means it doesn't, right? So it got it right or it didn't get it right. Next, the fourth column, the physician decides whether to accept or reject the AI recommendation. That's assuming they have a choice. There could be a future where they don't have a choice. And then we get to the fifth column. This represents the patient outcome. If the physician follows a correct recommendation or rejects an incorrect recommendation, the outcome is good. If the opposite, the outcome is bad in this very stylized example. And that finally brings us to column 6, which is the colorful one, which is the 8 possible scenarios that result. And the key thing to understand is that the law treats them differently. And understanding this just depends on basic tort law. If there's no injury, there's going to be no liability. That's the green boxes in the figure. This is a good outcome, whether it happens because the physician accepts a correct recommendation or rejects an incorrect recommendation. Second, though, tort law typically privileges the standard of care, regardless of its effectiveness in a particular case. So whether providing that care leads to a good or bad outcome, if you follow the standard of care for that case, you're largely going to be immunized from liability. The result is that under the current law, if you're a physician, you face liability only when you do not follow the standard of care and an injury results. That's just the safest way to use medical AI, is to confirm the thing you were going to do anyways. And when it tells you you should do that, you feel really good and you keep going. But when it tells you to do something you weren't going to do, now all of a sudden you worry about the liability. Well, that's okay, but if we think the medical AI is precisely valuable because it catches the cases where we should do something different than we're standardly doing, you're leaving most of the value on the table. And as your colleague, the late Professor Kerr, pointed out, and I think I saw Michael Frumkin at one point on the Zoom itself and the attendees, there could be a future where it becomes the case that using medical AI is the standard of care. So we could end up in a place where if you don't use medical AI, it would be like not using an EKG and just guessing at the rhythm or something like that. But truthfully, tort law and medical malpractice law is pretty conservative. It has a lot of respect for the respectable minority position. So I'm not that optimistic that we're going to get there anytime soon. And you might worry that the liability regime will deter some of the most valuable forms of medical AI. Okay, I want you to tell me after you listen to this if there's an AI involved and who the AI is. Sorry for people in Zoom land. We're just going to do this with the people in the room to vote. Go ahead. Yep, the little survey says.
How may I hear you?
Hi, I'd like to reserve a table for Wednesday the 7th.
For 7 people?
It's for 4 people.
For people when today,
Next
tonight?
Wednesday at 6 p.m.
Oh, actually, we reserve for like upper like 5 people. For people, you can come.
How long is the wait usually to be seated?
For when tomorrow or weekday or?
For next Wednesday, the 7th.
Oh no, it's not too busy. You can come for 4 people. Okay.
Oh, I gotcha. Thanks.
Yep. Bye bye.
Okay, stop there for a sec. So not trying to make you hungry, not trying to, it's anything like that. Just a vote. Who thinks, and again, I primed you a little bit. Who thinks, because I'm giving this a talk as part of a medical AI talk, just to be clear, right? If I stopped you on the street and asked you, maybe your answer would be different. Who thinks, just by a show of hands, an artificial intelligence is involved in that conversation? Who thinks it's about maybe 40% of the room? Who thinks the woman is an artificial intelligence? And who thinks the man is an artificial intelligence? Maybe 25, 30% of the room? That is correct. That's actually Google Duplex, one of its AI tools for making reservations that passes a localized Turing test where people are confused. But imagine if you were the woman receiving that call, would you have any idea that this was an artificial intelligence agent that's built to reserve restaurants? Now, the question is, is it problematic that that woman does not know, or that someone interacting with an AI does not know? Is it problematic if you don't know the basis for a recommendation about whether to get a prostatectomy or whether to get a particular, a mastectomy, for example, is based in part on an AI algorithm? Is there an obligation to disclose? And this cute little cuddly guy on the screen is Paro. He is the social robotic kind of therapeutic seal. He's given to old people who are kind of starting to experience sort of dementia, and they love him and they treat him like a pet, and it's wonderful, but he's also a little spy because he's recording all sorts of information about them and sending it back to their physicians. And many of them may not understand what's going on. Do we have a right to know when we're dealing with an AI? Does the law give us such a right? Probably not. And when it comes to questions about informed consent, I think there's some very interesting and difficult question. Is the involvement of a medical AI like failing to tell a patient that another substitute surgeon is scrubbed in, something that would clearly be a violation of the informed consent law? Or is it like failing to tell your patient that when you recommended a particular treatment, it was based on a dim memory of a lecture in medical school, 6 journal articles you read over the last year, 5 other patients you saw that reminded them of them, and probably what you had for lunch and whether you were feeling indigestion? We typically don't think when it comes to this black box that we have a right inside to understand what forms the physician's kind of attitudes and why they recommend something. Is it different if part of what informs that is an artificial intelligence? Doesn't matter whether the artificial intelligence is itself interpretable, we can get under the hood, versus more opaque, more of a black box sort of intelligence. Doesn't matter whether it's been reviewed by a regulator before it's put in place. How should the law approach these questions? Next slide, please. So we heard this in the previous talk just a few moments ago, is the question here about privacy and consent. So how do we think about the use of these agents, both in terms of our data, but also the possibility of data triangulation back at us, and the fact that artificial intelligence can piece together many pieces of information about us to know things about us? So this is not just of theoretical interest. We've already had lawsuits. This was one from the University of Chicago against the University of Chicago for its participation with something with Google where it gave health records. There was another one just filed yesterday, a class action against Cerebral relating to the Pixel technology and sharing the information. And what I want to point out to you, if you don't mind going to the next slide, what I want to point out to you is that the current law, especially in the United States, but also in Canada and even places like Europe with the GDPR, really focuses on what's above the waterline, not what's below the waterline, which is most of the iceberg. That is to say, in the United States, where our system of health privacy is very sectoral, right? It attaches limited data protection to traditional healthcare relationship environments. It's not a good fit for the reality of 21st century prediction of your health. And to put the point most forcefully, the data in the future that's going to best predict your health may not be your health care data. It may be all sorts of other kinds of data. And just to tell a story that I thought was apocryphal, but it's now been documented enough that I can tell you it is true. A man goes into Target, or Target, as people say if it's fancy, and says, "What business do you have sending my 16-year-old daughter all this information about diapers and pregnancy and stuff like that? What are you trying to say about my daughter?" The manager apologizes. It must have been a mistake. The man comes back 4 weeks later and says, "I'm here to apologize." Why? His daughter is pregnant. Target knew his daughter was pregnant before he did. How? Not because they're snooping in her healthcare records, but because they have all of these records about how people's behavior and purchasing habits change approaching pregnancy. And as a result, they can predict it. If we have a data regime that's focused on healthcare data, that's how we protect information about your health, we miss all of the ways in which non-healthcare data will be predictive of health. And unless we're willing to adopt a very omnibus general data protection regime, that means that if we think health data is particularly important because of its vulnerability, we're in trouble. Next slide, please. 2 more slides and I'm done. This one is just to say a little bit about bias. So this is probably, of all the things talked about AI in medicine, this is probably the most commonly discussed, but I'm going to tell you that we've only dealt with the most shallow version of the problem. The shallow version of the problem is you're trying to predict something and you're missing people in the data set. Your data set is largely white, and in fact, you're trying to predict it for an entire population that involves First Nations people, Caribbean, Canadian people, and the like. That is a big, big problem, a hard problem to solve, but it's actually a relatively easy problem to wrap your head around and identify. This paper, which is a very good one from a couple of years ago, shows a much more subtle version of the problem. Essentially, we're trying to develop an algorithm to prioritize who gets follow-up care in order to avoid declinations after someone is released from the hospital. A very good thing for an algorithm to try to do. And what they did was they used as a proxy about who is the sickest, who costs the most. They used healthcare cost data as a proxy. Ex ante, before they'd run that study, that seems like a relatively smart way to do this. We have a lot of that data. We track it for individual patients. But there's a problem. The problem is at the same level of algorithm predicted risks, Blacks have significantly more illness burden than whites. Why do these differences occur? It's because the key input to decisions about future enrollment in this care was cost data. And we know that actually Black patients tend to cost different than white patients just because of care-seeking activities and the kinds of activities they undertake. So if you tell your algorithm, please try to predict on the basis of cost, you end up producing racial disparities. And even if you decide to take the algorithm race blind as a way to think, hey, I'm ahead of this problem. And this is just a much more subtle and difficult problem. They call this label bias, the authors. And essentially it's subtle and difficult because it's hard to predict all of the ways this can go wrong ex ante. Unless you are committed to doing this kind of auditing, which is expensive and difficult and sometimes requires implementation, and doing it continuously, you're going to miss these kinds of bias. And it's not just race. It's many other variables of interest that are of interest to us. And we have to think a little bit as a society, how much are we willing to sacrifice poor performance for some subpopulations who may not be able to predict who they are ex ante in favor of larger average performance across the whole population? When does that make us queasy versus be appropriate? Okay, I think the last slide. Yeah, like I said, I have that thank you slide, but that's the last substantive one. This is just to say, one more thing to say about this is the question about explanations. So there's a big movement to say what we need is explainability. Be afraid of the black box. Now, that's a reasonable fear to have, but people have 2 very different solutions to it. One that I think is good, but limited, and one that I think is not so good. The one that is good, but limited is to say, in reaction to the black box problem, we're going to basically say we're only going to use interpretable algorithms, right? What do we mean by that? An interpretable algorithm does roughly the following. Instead of using a black box function, it uses a transparent or white box function that's an easy to digest form. For example, a linear model whose parameters correspond to additive weights relating to input features and output, or a classification tree that creates an intuitive rule-based map of the decision space. You can do this, but it's going to limit the kinds of models you can build. And in particular, it's going to stop us from using some of the models that are most exciting for medical machine learning because they are just not possible to render in interpretable form. Well, people come up with another solution, which is to say, instead of relying only on these simpler interpretable models, let's create white box models that essentially try to understand and predict what the black box is doing. So run a second algorithm to generate a white box model that can explain what the black box is doing. That sounds like a really good idea. Unfortunately, the end result is that these models typically give us what I refer to as fool's gold, right? They give us an explanation that fits the data we ask them to, but it may not be the explanation. And the best way I can illustrate this is by talking about going clubbing. I know you weren't expecting Chinese food and clubbing in this talk, but have to keep it interesting, right? I go to the club and I'm wearing sneakers. The bouncer looks at me and says, I'm sorry, you can't come in. I ask why. The bouncer says, it's because you're wearing sneakers. In fact, the reason I can't come in is because I'm a dude and I'm with 4 other dudes and there are too many men in the club at the moment. And essentially they want to keep the right balance. It is true that the bouncer explanation about my shoes does fit the data, but it turns out it's not the actual explanation for what I'm doing. And if I tried to offer other kinds of data too, I might get contradictory and other kinds of information from the model in terms of what it's explaining. So one thing I just want to say is that we face some real challenges about how much we value interpretability and explainability or not. We have to avoid the fool's gold. But as I tell people, you know what? Explanations are great. I love to understand how things work. But even more important to me is to understand that they work. Take aspirin. We have no idea or very little idea about how aspirin works. I take an aspirin when I have a headache. Why? Because there's a lot of clinical data suggesting it works, randomized trials and the like. We may face some trade-offs here between proving that various kinds of AI interventions work versus understanding them. And I think that's a real trade-off. I think in areas like criminal justice, for example, I think the trade-offs are different and maybe we need explanations because reason giving is part of the social practice. I'm less sure that's true in medicine, but in any event, I don't think there are easy answers here. Okay, I hope I've whetted your appetite and thank you all for adjusting to me and adjusting to the plane schedule. It's been a pleasure to talk to you and thank you very much.
So thank you very much for inviting me and very happy to comment here. Just a bit of a background. My PhD is in machine learning, which is what's most commonly used as AI. And I've been a professor in the area of machine learning in healthcare for the last 12 years. Developing what we do is we develop AI algorithms to be deployed at the hospitals. And I really liked the previous speaker's comments, and I want to go in a reverse order of what has been mentioned. So one of the things that was mentioned last was explainability, and I completely agree with the speaker regarding the over-reliance and the hope for what explainability is likely to bring to the table, that it is very easy to create an explanation that will appeal to humans that have nothing to do with the model. And that is not what the researchers are trying to do. But I don't think the goal of explainability towards trying to appeal to the clinician to explain the model actually serves the purpose that we ultimately want, right? What we ultimately want and what the clinicians want is they want to understand how the system works. And the way that we work with tools that we don't necessarily understand, such as the weight or the airplane or the fridge or something like that, is we try to work with a tool that is complex, potentially physically or mathematically, and we try to work with it and we put the inputs and we see what the output is. And this is something that I think clinicians will have to be trained in. So every tool that they will be interacting with, they have to understand exactly how it works, what outputs to expect. And this is the sort of the level of interaction with a tool and the reliance on the tool that the clinician will expect, I think, and will be needed to use the tool reliably. Now, there are some calls for instilling explainability into law. Or interpretability of the tool into law, and I think there's a big concern there from the community who is doing research in this area, because as was mentioned earlier, such explanations might not be reliable and might not actually be leading to the outcomes that are relevant to the clinicians and clinical care. Another thing I would really like to mention and to talk about is the equitability of AI tools and what's happening now in reality. And I think this pre-marketing idea as well, which is much beloved by a lot of the legal scholars. So what's happening right now with AI in healthcare and the AI in healthcare that we are developing is that it is really in some way is limited to the population it has seen during the training, right? We have a bunch of data that we try to build a system on, and it captures some population. Even in Toronto, which is a very diverse population, it still captures some subpopulations better than others. And it is quite possible that if we move from say an academic hospital to a community-based hospital, that it might work. But if we train the tool at the community-based hospital, it will not work in an academic hospital. So we can develop tools in particular settings, and then what people say, oh, we should try it everywhere. But the reality is you cannot try that tool everywhere in a way and shape and form that it is developed. Every time you move a tool from one hospital to another hospital, it'll have to be tested and potentially tuned to the population that that hospital sees, right? To make sure that it is appropriate for the hospital, for that population. And I think that is something that is not well understood by the community, and that has to be incorporated into sort of the legal system and how these tools are evaluated. Now, something else that was mentioned that is actually quite relevant to this topic is how well will it perform on some of the populations that it sees fewer of. So, for example, the African Canadian or African American population, and will it perform as well? And the problem is not just that the algorithms are built on cost. In Canada, we don't necessarily do that because we have a single payer system. But the problem is that there are a lot of mistakes that are done in care for a minority population or populations, or just other different kinds of the subpopulations that we see fewer of, because a lot of the initial studies based on which people are treated were done on unrepresentative populations, right? So a lot of the drugs that are administered or the procedures that are run, they have been tested on on the white folks like the speakers today, and the panelists as well. And so this begs a question of how well can we ever actually perform this AI algorithms can perform, since there is no data to perform well on the populations that the care has not seen before. So yes, there will be medical error, and the question is, how do we characterize it, and how do we stipulate, and in what format, to say this is the expected performance of this algorithm for what populations? And I think that is the very important point. And then we can argue whether a tool should go into production or into practice if it can only help a sliver of the population that has already been much helped before. So I think these concerns, some of these concerns are not necessarily unique to AI, but are sort of exacerbated by AI, because AI can be ubiquitous by definition. We can start building algorithms, and we do think that AI in healthcare is standardizing the better care, better practices, right? Because we can take the data from the top hospitals with the top care, and we can build systems there, and we can say move it to locations and potentially remote locations where we have not, where some of the professional expertise is simply not available. So this is the promise of AI tools, and part of the reasons we are working on them, to try to improve the overall standard of care across the world. But the populations and the subpopulations that may be affected still, I would say, affected still by the kind of care that we have experienced today, is not a solved problem. Now, I think there's a whole subfield, it's called fairness in AI, which is concerned with this issue, and we have been developing tools and testing tools in subpopulations for this purpose, to make sure that it really is performant on all of the different kinds of the diverse population that we see at hospitals. But it's a concern, and it's an area of research, and I think we can only do better as we go forward. Actually, in Canada, there is another issue with that, is that in Canada, at least some of the clinical systems do not collect race or ethnicity or anything like that. So there is no way to test how well the system will perform on people, say minority subpopulations. So that's another issue that I think AI researchers have brought to the front, and we are trying to change in Canada. But this is a really big issue for us to say the system is biased or the system is not biased, because we don't have the labels to check or the data to check. And finally, I want to just briefly comment on the area of sort of the data privacy. And I think there's a lot of discussion about privacy of medical data and what can we do and what we cannot do. And I think a lot of times there is a big concern that the way that this is talked about is brought to the front by saying AI might see who you are or might construct this impression and opinion of who you are. And the reality of the current world is that people share way more information. And if I remember correctly, the example of the sort of the diapers that were sent to the 16-year-old, it came from the fact that this was shared, that the person was either buying them or sharing some information on Facebook and other media as well. So there is information, a lot of information that people share willingly. There's information that people share at the hospitals.
Maybe 30 seconds, Stella?
Yeah, I'll be done in, yes, sorry. This is a very passionate area of mine. There is a lot of information that people share in a medical context, and they expect their care to improve over time, but it doesn't, right? Because when this data is taken and not analyzed, but it's sort of sitting in the silos because of concerns for privacy, there's no care that is improving, right? And we want, as patients, all of us are humans, and all of us are or were or will be patients. We want better care. And I think that's something that we have to think about and maybe change maybe change the rhetoric a little bit around this area, from being concerned about AI knowing about this to sort of what can be done with this data to help me as a patient to get better care. I think this is where AI researchers come in, like me, and this is our ultimate goal, is to really help the patients. So I will stop with this. I would love to get comments after, and I will pass it to Catherine and Maggie.
Thank you so much. I'm going to start by the phrase that you've all probably heard before, and that's nothing about us without us. So I'll start by stressing just how important it is to have patient and caregiver involvement in the development of AI in medicine, its implementation and its governance. As I prepared a little bit for today, I thought about how we understand success in healthcare. Since the AI algorithm's goal is to predict success, they have to define success very specifically. But the truth is that when you're dealing with real people, preferred outcomes are not black and white and are not singular. So just as patients and caregivers have advocated to be part of designing outcomes in research, I think it'll be important to determine, define, and embed the patient and caregiver role in defining what a successful outcome is in medical AI. And for me, at probably a more fundamental level, one of the cautions that I have around AI is ignoring our humanity, or the potential of ignoring it, and the power of our stories. Data alone is not enough to provide excellence in healthcare. Patient stories are often the source of diagnostic or treatment solutions. They provide the missing pieces that often lead to those sort of aha moments in a clinical plan. It's our stories that provide context, that explain the whole person, our environment, our fears, our desires, and our limitations, not data alone. So I worry about the possibility of AI reducing us to a specific demographic, a diagnosis, or a disease profile, rather than the whole people we are. And I'm going to present a bit of an alternative conclusion to what Professor Cohen did, in that I think there's the potential that AI could result in actually less personalized care and more homogenized care, because it doesn't take all those things into account. So at its core, I believe that medicine is about humanity, about touch, about communication, about relationship. It's the reason that we refer to the art and science of medicine. I was struck by the mention of an ICU case that you presented, Dr. Cohen. Early in my career, I worked in the ICU where we used a calculator, not AI, to calculate what was referred to as an Apache score within the first 24 hours of ICU admission, and which was designed to predict ICU outcomes. But what made it an unreliable tool was that I worked in a downtown hospital that served a higher proportion of people experiencing homelessness and addiction than in other parts of the country. Their scores were significantly lower than average based on the data that was input. But counter to their scores, the reality was they actually often did very well clinically. Especially in a fiscally constrained environment, the potential exists for scores like this to be used to determine who receives treatment and who does not. That potential is an ethical nightmare and would be an affront to the values inherent in Canada's universal healthcare system. Relying on historical data, AI algorithms propagate past practices. So Anna was talking about the potential for bias, particularly for underserved groups or underrepresented groups. So if AI propagates inequity or bias, it will pigeonhole people based on the data that's fueling the algorithm. I don't want to talk about privacy because I think bigger brains than mine are certainly looking at that, but I do want to touch on data ownership for a moment. It's problematic for many patients to contemplate the ownership of their data being with a third party that they have no sightline to, and where there is the potential of it being monetized for profit without their consent. I think it's important that we think through the implications of profit-driven versus patient-driven systems and find ways to appropriately govern their use. I read this week that Microsoft has made a business decision to eliminate its AI ethics department. Profit drives decisions in business, as one would expect. Nonetheless, it's important for us to think about these decisions and understand that they will happen and they will impact all of us. The closed, opaque, and siloed nature of privately owned AI systems is a worry for patients. What data are used? How complete is that data? Who decides? Who consents? Why can't I see it? Outsourcing healthcare AI development means we also outsource accountability, and that is deeply troubling for patients. By outsourcing accountability, mistakes may not be caught, complaints may not be able to be filed, so remediation and positive change won't occur. When no one in particular is responsible, then when there is harm to an individual or a population, we have a responsibility, I think, to ensure that there is accountability, transparency, and clear paths to identify and address harms. We are long past the days of saying that patients aren't smart enough or sophisticated enough to understand data or clinical scenarios. The reasoning that AI is too complicated for us to understand, that since I am not a coder or a mathematician, I therefore won't understand it, is unacceptable. We have to move away from this kind of paternalistic healthcare to participatory healthcare, and that includes the patient. A friend reminded me that technology will only help bridge the cracks in the system if we fix fragmented relationships and burnout and the it's someone else's problem issue. The irony of talking about this amazing new technology today, while we're still not getting the foundations right, isn't lost on me, and it needs to be addressed. AI is exciting and has the potential to absolutely revolutionize healthcare. Yet, we still rely on faxes to send referrals and requisitions. We still can't provide patients with full access to their medical records. And major academic centers still cannot exchange diagnostic imaging. In my view, what we need to prioritize is the design of a comprehensive, coordinated health technology ecosystem, where activity across the system, including AI, is seamlessly and reliably synced, and where the information is readily available in real time to patients and providers across care settings. There is no value in trying to stop technological progress, especially when that progress has the potential to help many. But I do think we have a responsibility to figure out how to best use it, monitor implementation, and govern its use, including with patients. Thank you so much. I'm going to stop there. I know people have questions that I'm sure they're anxious to ask.
Thank you very much, Maggie, for your important perspective. So we have a few minutes for questions. I suggest that Colleen and Glenn go in front. Is there any question in the room? Otherwise, I have one question in the chat, but I just want to ask before. If you do, I'm going to give you the mic, actually, so we can all understand you. You do? No? Okay, you want lunch? Okay, so the first question is, are there increasing number of AI uses for healthcare purposes done under nonprofit? Does the organization, whatever, you can read, organizational structure, nonprofit change the value under which healthcare AI is governed? Yeah.
After you first.
So just to understand the question, it's about non-profit versus for-profit. Is there increasing number of I don't know the answer to that. I think what we've seen in the work is we've been doing a lot of case studies of AI technologies and in health and kicking the tires. A number of people in the room, my colleagues, have been involved with this. And what we have seen is quite a gap between what the innovators are doing and then what potentially may happen when it's commercialized. So the innovators, for example, we were working on a self-driving wheelchair. You know, they had really thought hard about how to protect the privacy of the occupant of the wheelchair and those around and these kinds of things, and had done a lot of work on that. But then when we were, you know, asking the question, well, what would it really inhibit the subsequent manufacturer of this, you know, once it's commercialized, from collecting all of that data? The answer was, well, nothing really, you know. So there seems to be a gap between people like Anna and other innovators, and then, you know, what the commercialization, you know, of potential data, which, you know, is obviously something that will happen. So I think this might go to the issue of, you know, trying to think about the design early on, and some of our wonderful colleagues here work on that issue. So trying to inculcate, you know, the best kind of safety features in design. And that's also, I think, why I just want to keep pressing on my theme of, you know, the sort of pre-regulation, pre-market regulation, to sort of send those incentives back to designers and those who commercialize to adopt best practices in, you know, privacy protection, where possible, addressing algorithmic bias, you know, to do those things, and to have that incentive flow from a central regulator. So I don't know if I answered the question. I didn't, but maybe Glenn can do better.
No, I think it was a very good answer. The only thing I'll maybe just add is that there is typically a lot of the data that's used to train algorithms is collected by the public and then is used to commercialize items that are in the private. And sometimes these agreements are very interesting, and some of them have come to light because of litigation over them, for example. And I think that it is not the case that we ought to have all of the innovation happening in the public sector. We're not going to get all the innovation that we could have and could benefit. But at the same time, there is this question that when you have a healthcare system that is collecting this data somewhat as a byproduct of what it's doing, if there's not reinvestment back into the healthcare system from these kinds of, and it's not done consistently with the goals of the healthcare system. And I'll just give you an example here regarding the Apple Watch, for example. This is an interesting, I think, case study. Apple rolls out this watch that can detect cardiac problems and atrial fibrillation, for example. But the decision about where to put the threshold between misses and false positives, for example, actually has a major impact on the healthcare system, because if you overdiagnose and over-alert atrial fibrillation, you then get many more patients going to the hospital system saying, I have AFib. You have emergency rooms that have to deal with this and have to determine that. So that is a decision where you might think how to set the receiver sensitivity curve is one that has major externalities, and yet in deciding where to set it, it's not clear that, for example, the hospital systems in a locality alike are consulted. So I think that's an interesting example of the place in which the public and the private are not necessarily jiving together.
So I think, Anna, you want to add something, right?
Yes. So I just wanted to, I wanted to make a comment about something that Maggie said in terms of what AI, that AI can make care less personal, less personable, less humane and human. I think everybody who is developing systems now is hoping that we will use AI to help clinicians make better decisions, but it is clinicians that will be interacting with the patients. Ideally, we will be saving time, making, sort of the background work more efficient so that the clinician can spend more time with the patient. So my hope is that ultimately the clinician will be able to spend more time with the patient when AI is in use rather than less time. And really, we view it as a sort of augmenting care in the way that potentially blood work augments understanding of what's happening with the human body, but just based on a lot of data that's been collected. I just wanted to make sure that there is sort of an understanding of the primary purposes of the AI that's being developed now.
Oh, there's a question. Okay. I guess, yeah, I'm gonna go. Yes, okay. It's for you, it's for you, right?
We both had it.
Two? Okay, go ahead.
I'm curious about the overlap of genomics and AI and whether genomics presents any solutions to personalization or filling some of the gaps when we talk about like subpopulations that may be overlooked or biased.
I'm happy to take that question. I have a controversial opinion in this area, which is the majority of the genomic studies, especially when they're not sort of, but even genetic studies, are done on rather small populations and small and often non-representative populations. So there's very little of the genomic work that actually makes its way to the clinical practice right now. Another concern that I have with sort of integrating genomic work is that it measures the state of the cellular and molecular processes in the human at this point, right? At a given time. It's most often the human, especially the trajectory of the disease, it causes the development and change in these markers that is not captured over time in genomic studies as well. So there isn't even research that could, not a lot of research that can help to guide and understand the human at a given point in time because there's just not enough data to train on. So I personally started in the computational biology space some 14 years ago, and over the last 5-6 years, I have moved more to the electronic medical records because there's more data that is immediately clinically relevant and physiological data that is immediately clinically relevant, and I'm waiting for the genomic data to catch up with sort of the with the breadth and the speed and the extent of what we need to incorporate into AI algorithms for clinical care.
Hi, thank you for amazing talks. To give some context, I'm one of the PIs on the NIH project called Bridge to AI that looks at how to ethically design data collection and machine learning in health. And one of the papers we're currently writing looks at the tension basically between the last two commentators, between explainability and interpretability on one hand, and the efficiency and the predictability and everything that a patient wants from a clinical perspective. And we're analyzing this as a tension between values. We're looking at theories that analyze value conflict and how they would apply to this. So I am dying to hear what the last two commentators have to say on this from this perspective of just two sets of values coming into direct conflict and how we weigh them against each other.
So I'm happy to start. I mean, I think it goes back to the principle that I spoke about at the beginning, which is including patients and caregivers and the public in the design and development of AI in medicine, as well as its implementation and governance. So, you know, I think that really a robust participation, rather than just asking at the end if patients and caregivers like what they're seeing. I think that co-design principle, if that's what's at the heart of it, I think that we'll make great strides in finding ways to bring those values together.
Did you want to comment, Anna?
Yes, I'm trying to think of what I think some level of understanding what the system is doing is definitely important. The question is, what information is needed and most helpful to make sure that we establish the trust and understanding of how useful the system is in a given context. And I think that is still sort of an amorphous subject area that we are all struggling with. And I think I would be fascinated to read what you find. I think the value, the question is, what is the value of the explanations that is generated by the system? And this is not necessarily what value it can provide, but in the context of what it's actually given, how actionable it is, how faithful it is to the process, that the underlying process that it's trying to capture and trying to describe. I think all of those issues have to come into play to assessing those values of explanations. And I think it's not obvious that the field of explainability is big, and there are a lot of opinions about what is important, and making sure that we do not over interpret the system. I think one of my favorite research papers in this area has shown that when we provide explanations for a system that is underperforming, right? This tension that you talked about, that when we provide explanation for the system that's underperforming, it lulls the humans who use the system into thinking that they understand, and they tend to overlook egregious errors that they would not in a system that they were sort of weren't so comfortable with. And this is an experiment that was done in a paper by I think some of my colleagues at Microsoft, who sort of bring this to the forefront, that explainability is sometimes detrimental to the human AI interaction and the efficiency and the value of the human AI interaction.
Yeah, I think we just give Glenn time to one last comment before we wrap up.
Sounds good. So I'll say, Vardine, on this, that to me, it's about confidence and more than understanding. That when I'm a patient and I go in, I want to make sure, there's someone who's looking out for my interests, and I want to feel that I have confidence in the judgments they're making. Their understanding of what's going on gives me some confidence, but so does other forms, other epistemic warrants, as the philosophers say. And to me, when I introspect as a patient, if you told me, I can tell you, I understand how something works, or I can give you data from a clinical trial that it produces positive effects. Choose A or choose B, which of the two you want. I probably want the clinical trial, but that's me.
Me too.
Okay, so our time is up. I think before we finish, I would really like to ask you a final question, and you can answer like very quickly. So we spoke a lot about the legal challenges, right? All the issues, but not a lot about the solutions. So in ending, I would like to ask each of you, if the law could do something very good in the next years in regulating AI, what that one thing, that priority would be for you? And we can start by Maggie, perhaps.
So I'm going to start with what I closed with, which I think, we have to come up with a strategy that integrates AI into the larger health technology ecosystem. Certainly we don't have a provincial strategy, never mind a national strategy. So I think doing that will help to integrate care and integrate AI into practice.
Thanks, Maggie. Colleen? Oh, Anna? Yeah, online.
Sorry, I was responding to somebody online with a question about the talk, so I missed your question. I'm very sorry. Can you repeat it, please?
The one thing you would change in the next years for a legal regime to better regulate AI, the really one thing we should focus on, what would that be?
I think, well, first of all, I completely agree with Maggie. I also would really love this inter-provincial differences to go away. That would be really great.
That's a very long-term project.
Yeah, I feel that everybody thinks that they are smarter than a neighbor, and they come up with decisions that are slightly misaligned with another province, which makes it really difficult to share and to collaborate across. And this just makes the innovation harder and makes better care worse. So, but in general, I think changing the lens, as I was saying in the comments, changing the lens on the discussion of privacy, I think would be very helpful. And to the more positive view of what it can do for the patient, seeing how the patients can get engaged. I feel like all of our work right now is centered around what clinicians say, these are the helpful tools for us. The perspective of the patient saying, this is the kind of tool I would like when I come to receive care. That would be amazing, but we don't really have access into that. And I think having that voice in the legislature as well, when the tools are being developed and prioritized and going into practice, I think would really help as well to making better care.
Thanks very much. Colleen?
So, I just go back to what I said at the beginning, Catherine, that same thing, meme shows. I think that, that we have an opportunity here through federal regulation, through Health Canada, to really make the right platforms for Canadian AI innovation in healthcare that can set appropriate standards across the whole jurisdiction. We rarely get that chance in Canadian healthcare because of provincial jurisdiction. This is our one great opportunity to really make a great leap forward, I think. So, not too much pressure. I know there are a few people from Health Canada here, not too much pressure, but, I think we have an opportunity to do something pretty wonderful for Canadian patients and for Canadian innovators and clinicians, because I completely agree with you. It's about confidence. I might say trust, right? That clinicians can trust the technology, that patients can trust the technology, that we support amazing innovators and companies, that they get their products through lickety split. But we have, we weed out the problematic ones, and we send all those right incentives about fantastic, doing fantastic design from the get-go with good regulatory structure. Now, that's not easy. And, we're flat-footed a lot of time when it comes to regulation and legal responses, but like dinosaurs waiting around in the swamp, waiting for the comet to hit us. So we got to get a lot smarter, faster, flexible, and innovative, and actually use some of these technologies to help us regulate as well, which is another kind of talk.
I'll just say maybe less of a focus on form, more on substance. So it shouldn't be that how the regulation applies depends on whether you're built into a device versus built into an app versus freestanding. Shouldn't matter whether it's within a hospital or outside a hospital. Instead, we should be regulating everything that poses the same risk the same way. But the way the regulator pie is divided up, it has these fiefdoms that are much more about form. And I'd like to try to erase those if I could.